Hi, good afternoon, everybody, and welcome to our Pallaborative Northwest Clinical Audit presentation. I'm sorry that we're a few minutes late in starting. We've just had a few gremlins in the system, which I think we've managed to resolve now. So today's presentation is the long-awaited guideline development group presenting their work on ascites, and they've had to wait a very long time to do this because of COVID. So we're really looking forward to hearing the results from the literature review and the audit and the new standards and guidelines, because this is such an important topic for the patients we look after. So without any further ado, I'm going to hand over now to the group who are going to talk us through their findings. Thanks very much.
Hi, can I just check that you can hear me okay?
Yes, you're live.
Brilliant. Okay, I'm Laura, I'm one of the Regers, and I've got a couple of people with me that I'll introduce now. So if we could just have the next slide, and I'll take you through the structure of today. So I'll be presenting the introduction, and we've got Dr. Aileen Scott, who'll go through the previous guidelines. Dr. Sarah Fradsham will do the literature review. We've got one of the nurses, Sarah Stanley, who'll do the audit results. I'll do the proposed standards and guidelines, and I will just read extracts from the people's voice and the experts, and then we'll have the discussion at the end. So if we move on to the next slide, our group was comprised of lots of different people from different hospitals, and we've, just as Alison said, been doing the ascites audit for quite some time now, which was obviously delayed with COVID. Okay, could we have the next slide, please? Okay, so I just wanted to start by asking a couple of questions. I just thought if you could have a think, if you're in groups, have a discussion, but if you're on your own, just have a think about the answers to these questions. You don't necessarily need to put them in the chat unless you want to. So non-malignant ascites then. What are the most common causes of cirrhosis? What is the mean time period from development of cirrhosis to the development of ascites? What is the mortality rate of patients at 2 years with non-malignant ascites? And what is the mortality rate of patients with non-malignant refractory ascites? So if I just give everybody kind of 30 seconds to a minute just to have a little think about the answers to those questions. Okay, can we have the next slide, please? Okay, so if we just go through some of these, so the most common causes of cirrhosis, I'm sure most of you will know: non-alcoholic fatty liver disease, hepatitis B and C, and alcohol-related liver disease. The next statistic, I must admit, which I was quite surprised by, which is why I've included it, that actually the mean time period from developing cirrhosis to developing ascites is actually 10 years. So they're actually quite far into their disease process by the time they develop ascites. The approximate mortality rate of people at 2 years with non-malignant ascites is about 50%. So again, to me, that was quite surprising and quite shocking. And then once you develop non-malignant refractory ascites, the mortality rate at 1 year is 50%. So by the time these people with cirrhosis or non-alcoholic fatty liver disease, whatever their cause is of their end-stage liver failure, they're already quite advanced in their disease process by the time they get ascites. This slide was really to highlight that. If we move on then to malignant ascites, could we have the next slide, please? Just again, some kind of questions just to get you thinking about malignant ascites in some of the patients we see. What percentage of patients with ascites are due to a malignancy? What is the most common malignancy that causes ascites? I know there are lots, but just the most common one. Approximately what percentage of patients present with ascites as their first presentation of an undiagnosed cancer? And what is the median survival of patients with malignant ascites caused by both ovarian cancers and other types of cancers? So again, just kind of 30 seconds or so to think about those answers. Okay, can we have the next slide, please? So the answers will come up in a second, but it's estimated to be about 10% of people with ascites have ascites due to an underlying malignancy. And ovarian cancer is kind of by far the most common types. So up to 75% of people with ovarian cancer can present with ascites at their initial presentation in primary care. Approximately 50% of people present with ascites, and that's their first presentation of an undiagnosed cancer. So always kind of thinking about people with ascites, whether they have an underlying malignancy that hasn't been diagnosed. And again, I included the statistic at the bottom just to highlight that ovarian cancer, the median survival once they develop malignant ascites is 10 to 24 months. Obviously, that depends on so many different factors. But the other types of cancers, they actually have a much worse prognosis. So thinking about people with malignant ascites due to other causes, their survival, the median survival is between 1 and 6 months. So they might need a lot of kind of specialist palliative care input once they get to this stage. Okay. If we just move on to the next slide then, and we'll just briefly cover the pathophysiology of both non-malignant and malignant ascites. So we've already said non-malignant ascites tends to be caused most commonly by hepatitis, non-alcoholic fatty liver disease, and alcohol-related liver disease. And there may be up to 10 years before they decompensate from their cirrhosis and develop ascites. So they tend to have portal hypertension, which causes splanchnic vasodilation. The RAS system is activated, and that tends to cause the body to retain sodium, which develops then into ascites. They may go on to develop hepatorenal syndrome, and the reason that happens is because of the vasodilation caused by the portal hypertension. You have peripheral arterial and splanchnic circulation kind of vasoconstriction because there is a reduced circulating volume. So there is a physical process that's constricting the supply to kind of both of the kidneys, as well as the water and the sodium excretion already being affected and developing ascites as a result. And as everybody knows, they have a significantly affected quality of life. If we move on to the next slide, just showing you malignant ascites is caused by different processes, so it's important to remember that. The most common causes of malignant ascites are ovarian, endometrial, breast, esophageal, gastric, lung, pancreatic, hepatobiliary, peritoneal, but that list is not exhaustive. They get fluid accumulating in the peritoneal cavity because of inflammatory cytokines, which change the vessel permeability and allow the ascites to accumulate. They also have impaired lymphatic drainage due to micrometastases. So there's two reasons why they get ascites. And again, as we all know, significant impact on quality of life. So if we could just move on to the next slide, I'll hand over to Aileen.
Okay, thanks, Laura. So if we could go on to the next slide, please. So we'll just have a quick overview of the previous guidelines, which are from 2009 and which were written by Leslie Alsop, Karen Rose and Laura Chapman. So next slide, please. So there were 4 standards in those guidelines. The first was that patients who have symptomatic ascites should have paracentesis within 48 hours of presentation, that all patients starting and taking diuretics should have U's and E's checked. Thirdly, the IV fluids and albumin shouldn't be used routinely for therapeutic paracentesis, but may be used in hypovolemia. And fourthly, that abdominal drains should be removed within 24 hours of insertion, unless there's a good reason otherwise. Next slide, please. So just to go through some of the recommendations in the previous guidelines. The diuretics, it was said that it should be considered in every patient with ascites. UNEs should be checked, and there was some guidance as to the choice of diuretics and also the doses. And diuretics is something that we did include in our literature review and this guideline. Next slide, please. So the guideline also looked at paracentesis, and there was recommendations as to how quickly that should be undertaken, Interestingly, it stated that if there was expected to be a large volume paracentesis, then imaging wouldn't be required, and I think practice has changed since that time. There was guidance that we should consider checking bloods. Clamping is not often required, and that fluid should be drained quickly. As with the standard, IV fluids weren't routinely recommended, nor was albumin, and there was some absolute and relative contraindication given. Next slide, please. This guideline also covered PV shunts, and this was something we discussed at the start of the project as to whether we would include this in our guidance, but the feeling was this is not currently part of clinical practice, so we haven't looked at that. This is part of our guideline. Next slide, please. And then finally, the previous guideline had recommendations around using octreotide in chylous ascites, and octreotide is something that we considered as part of this. We also had a discussion about whether to include systemic chemotherapy and intraperitoneal chemotherapy, but as we didn't feel that this is currently clinically relevant, so haven't included that in this guideline. And I'll hand over to Sarah Bradshaw to discuss the literature.
If the slides are they still up? If you can see them, I'll talk through. We've lost the visual. Karen, are they still up with you?
Yes, they're still up.
Okay. So I'm just going to talk through the literature review. So the first slide, please, Karen, the clinical questions. So the questions we used for this literature review were, I guess, just what we wanted to do with this group is explore non-malignant ascites, and we made a decision to include that, which is a change from the previous guidelines. So we looked at 2 clinical questions. So the first was, what is the evidence for the best medical management of malignant and non-malignant ascites in patients with life-limiting conditions? And the second question we looked at was, what is the evidence for the best interventional management of malignant and non-malignant ascites in patients with life-limiting conditions? So thinking about things like drains. Next slide, please. So moving on to our PICO. So the PICO that we looked at, so the population we looked at was adults with life-limiting illness and ascites, so they were people with malignancy and without malignancy. The interventions that we looked at, as mentioned, were medical interventional treatment, and the comparator in this group was no treatment at all. And the outcomes that we were looking at were relief of symptoms associated with ascites. Next slide, please. I'm sorry if this is out of sync because I can't see the visual. So the medical therapies that we looked at were salt or fluid restriction, diuretics, and octreotide. And the interventional therapies we looked at were paracentesis. We did look at peritoneal, or we included in the literature review shunts, but then we decided to exclude them at a later stage. And we also looked at fluorex drains because that was an area of interest and one that people had mentioned that they wanted including. Next slide, please. So our search strategy is just as demonstrated in the diagram, which just kind of summarises what we've talked about. We used the Medline, Embase, Cochrane, NICE databases, and then we also performed a hand search, which given we started this project quite a long time ago, there were some extra things that were included in the hand search when we completed that. Next slide, please. So I'm hoping you can see the flow chart. So there were a significant number of papers that were included in this review. So the total number that we got following our literature search was over 1,000, of which a lot of them were excluded because of duplicates or because they weren't relevant. But we did go on to review 92 articles for full text review, and then 45 of them were included in the review. So I guess it's worth noticing that of those 45, only 8 of those were randomized controlled trials, and most of the randomized controlled trials were the use of diuretics in people with cirrhosis rather than with malignancy. A bulk of the evidence was retrospective and kind of reviews, case series and qualitative studies. So despite there being a lot of papers, there was still kind of a bit of a lack of evidence of the kind of high level evidence there. Next slide, please. So once we got the papers and we decided what we included, we went through and graded them using the standard things that we use in this group. So we used the levels of evidence, and then the grades of recommendations have been used in our guidance. Next slide, please. And if we move on to the slide that talks about national guidance. Thank you. Thanks. So this was, sorry about that. So this was an additional paper that I thought was worth discussing. So this actually came out after our initial literature review. So it came from the British Society of Gastroenterology, and it's a paper that's on the guidelines of management and ascites in cirrhosis. So it came out in October 2020, so it's very recent, and it's based on a comprehensive literature search and systematic reviews in key areas, which included paracentesis, diuretic use, and the use of albumin. So very relevant, I guess, to what we were looking at. So I'll just whiz through some of the suggestions from this paper, and we have incorporated some of this into our recommendations. So in terms of salt restriction, so patients with cirrhosis and ascites should have a moderately salt-restricted diet, and that was kind of from moderate evidence, and their recommendation was that it was quite strong. Patients with cirrhosis and ascites should have nutritional counselling. Next slide, please. So then it went on to talk about diuretics, and it talked about potentially using spironolactone as monotherapy in the initial use with patients with cirrhosis, and then combining that with furosemide if that was needed. They recommended for patients with cirrhosis that ultrasound guidance paracentesis should be used when it was available, although that was not a definite, and that routine, I guess an interesting point, that routine measurement of clotting and platelet count and infusion of blood products is not necessarily recommended. And then albumin should be infused after paracentesis of greater than 5 litres in patients with cirrhosis. Next slide, please. So there was a mention of palliative care in this paper, and it talked about patients with refractory ascites who are not undergoing evaluation for liver transplant should be offered a palliative care referral, and that other, apart from repeated large volume paracenteses, that alternative palliative interventions for ascites should also be considered. And it talked about future studies should assess the kind of feasibility of long-term abdominal drains such as thorax drains in this patient group. Next slide, please. So one of the other things that we thought people would be quite interested in today, and that might be a change in the guidance, is the use of thorax drains, which I think since the previous guidance has come out, this has been a new thing that maybe some people have seen used in practice. So we wanted to look at some of the evidence for this. So this was a recent study again, which came out at the back end of last year, which was actually after our previous literature review. And this was a feasibility randomized controlled trial looking at long-term ascitic drains, such as a pleurex drain, versus large volume paracentesis in patients with refractory ascites due to cirrhosis. So again, in that non-malignant group. So it was a 3-month study which included 36 patients which were randomized. So 19 of them had large volume paracenteses and 17 of them had long-term acidic drains. I guess interestingly, all of them had prophylactic antibiotics prior to the procedure. And then the study looked at care-related costs and the percentage of study time spent in hospital. And both of those were longer in the long-term acidic drain group, so in the kind of Fluorex drain group. And the qualitative data suggested that the long-term acidic drains could transform the care pathway in this group of patients. They felt that it demonstrated that this was feasible, safe, acceptable and effective, and a reduction in the kind of need for health resources. So I guess they suggested that this should go on to be looked at further. Next slide, please. So then just NICE has also produced guidance on the use of Fluorex drains. So this was initially done in 2012, but then was updated in 2018, and this specifically looks at malignancy. So they looked at kind of based their evidence on 9 observational studies, so no randomized controlled trials, but 2 were from within the UK. 6 were a case series with 10 or more patients, and I guess the other 4 were kind of lower impact papers. So 1 was a qualitative case series with 4 patients, and the other 3 were case report. Next slide, please. So just looking at some of the kind of bigger papers in that guidance. So the first one was a single centre retrospective comparative case series, which looked at 40 patients who had Fluorex compared to 67 patients who had large volume paracenteses. But there were over kind of nearly 400 procedures in total, because some of those patients had repeated paracenteses. And the complication rates were the same for each. So when NICE was looking at the guidance around Fluorex, the things that they were looking at were kind of cost effectiveness, complication rates, how long the drains last, so how long they remained in patent for. So the second study that they looked at was 34 patients that were treated with Fluorex, and of those 20 patients had complications, a lot of which were minor, and only 2 drains needed removing. But they did show a significant kind of improvement in the quality of life of these patients and a reduction in some of their kind of symptom burden. Next slide, please. And one of the other bigger papers that was included, so there were 50 patients in this study with 52 Fluorex catheters used. So this was a retrospective case series. It kind of showed a relatively low complication rate in this. And actually the kind of average number of inpatient paracenteses performed before Fluorex was inserted was 5.3. And I guess that might be a discussion point that we move on to later, as for how many repeated drains you might need to have before there is a contemplation of a long-term drain. Next slide, please. So the recommendations that came from NICE was that the case for adopting Fluorex in the NHS is supported by the evidence, and available evidence suggests that Fluorex is effective, has a low complication rate, and it has the potential to improve quality of life. It can enable early and frequent treatment of symptoms of ascites in the community, and should be considered for use in patients with treatment-resistant recurrent malignant ascites, with an estimated cost saving of kind of £1,000 per patient compared with an inpatient large volume paracenteses. So that was what NICE recommended, and I guess the other literature that we looked at in terms of Fluorex kind of in malignancy found similar things, but they were mainly retrospective observational studies. Next slide, please. So the other things that we looked at that we thought people might want to know about the evidence for were octreotide. So really, the evidence for using octreotide is pretty small, but it was one of the papers it was one of the areas where there did happen to be a randomized controlled trial. So this study, which was from 2012, I think, showed 33 patients with malignant ascites. 16 of them received intervention, 17 were in the control arm. So the intervention in this paper was 30 milligrams of IM octreotide every month. Both groups had paracentesis 3 days after randomization, so they kind of started at a level playing field, and then they were monitored monthly. And the results showed that the median time for paracenteses was 28 days in the octreotide arm versus 14 days in the placebo arm, suggesting that there was a benefit from octreotide. And that when they were looking at quality of life, the placebo arm described worse abdominal bloating, abdominal discomfort, and shortness of breath. Next slide, please. When we went on to look at diuretics, the majority of the papers that included diuretics were in non-malignant ascites, where the evidence is of slightly higher quality. When we were looking at malignant ascites, because we thought that might be a particular area where people wanted to know whether there was any evidence, there was an observational study of 16 patients with malignant ascites, which was looking at kind of the acidic fluid characteristics and whether diuretics would work better based on why you kind of had ascites. So they compared people with peritoneal carcinomatosis, those with chylous ascites, and those with hepatic metastases with portal hypertension. And what they found is that patients with peritoneal carcinomatosis or chylous ascites are not in the kind of high renin-aldosterone state, so diuretics are less beneficial, which kind of refers back to the pathophysiology that Laura was talking about previously, but that those with malignant ascites, which is due to hepatic mets, behaved a little bit more like those patients that have kind of cirrhosis, and so they might be more likely to respond to diuretics, which we thought was quite an interesting point and might kind of guide people's use of diuretics in malignancy. So I'll pass you over to Sarah Stanley now to go through the order results.
Okay, so I'm just going to talk you through the audit results. So if you go on to the next slide, please. So these are the results from the surveys, which are the healthcare professional survey, case note survey, and institution survey. If you go on to the next slide, please. And this chart shows you where the episodes of care had taken place, and at the bottom there you can see that the majority were in specialist palliative care settings. And if you go on to the next slide, please. The majority of the patients were female, and you can see the age range there was from 19 to 89, with the median age range of 54. If you go on to the next slide, please. Okay, you can see from this graph the locations of episodes of care. So the majority there in the yellow is hospices, followed by hospitals, and we've also got in the smaller sections nursing homes and patients' own homes. If you go on to the next slide, please. We asked about the causes of ascites, so it's quite unsurprisingly that most of the causes of ascites were malignancy. This slide's got a couple of animations on, so if you press on to the next slide, please. You'll see there the list of the different types of cancer in the patients who have ascites, and if you click on again, you'll see that the causes there of liver cirrhosis. And if you move on to the next slide, please. We asked about symptoms that the patients had reported. So unsurprisingly, one of the main symptoms was abdominal distension, and also not surprising to see that alongside that came pain or discomfort, dyspnea and nausea. If you move on to the next slide, please. And we asked about, prior to this episode of care, if the patient had received a previous paracentesis. Just over 35% had received previous paracentesis within 2 to 6 weeks, but also around that mark it was no that they hadn't. If you move on to the next slide, please. We asked about low salt and restricted fluid diets, and if there was any evidence that the patients had been advised on these diets, and we weren't too surprised to see that the majority of patients hadn't been advised to take a low salt or restricted fluid diet. If you move on to the next slide, please. We asked about diuretics. So asking at the start of this episode of care, was the patient on a diuretic? That's the graph on the left there, and the majority of patients weren't. And the graph on the right shows that a diuretic didn't tend to be commenced during this episode of care, but also that it wasn't contraindicated. If you move on to the next slide, please. The data showed that the unis tended to be checked within 7 days prior to commencing the diuretic. Only 9 patients had diuretics increased during the episode of care, and 1 patient showed improvement in ascites. And there was at least 47 patients commenced on diuretics. There was a small number of complications with the diuretic therapy, and that they were reported as reduced renal function, electrolyte disturbance, and hypertension. We move on to the next slide, please. So we went on to ask about paracentesis and where the paracentesis was performed. So this slide shows that 83% of patients underwent paracentesis during this episode of care, and 100% of those were planned. If you move on to the next slide, please. We asked who performed the procedure. So the majority were doctors who were based on a specialist palliative care unit. And this highlights that not all paracentesis are performed by interventional radiology. We move on to the next slide, please. We asked if the procedure occurred within 48 hours of the patient presenting with symptoms of ascites, and this is in line with the current guidelines, and just over 45% reported that yes, the procedure did occur within 48 hours. And if you move on to the next slide, please. So we went on to ask about clotting. 80% had platelets checked within 48 hours of the procedure. 67% had platelets greater than 100, and 3.5% had platelets less than 50. 4% had a platelet transfusion prior to procedure, and 75% had INR checked within 48 hours prior to procedure, and the results are on the slide there. 30% were also on an anticoagulant or antiplatelet. We did ask how long prior to the procedure the anticoagulant was stopped, but we were unable to pull that data out in the detail we would have liked. The slide up on the screen at the moment shows that the patient asked, did the patient suffer any complications of paracentesis, and the majority reported that no, they didn't. If you move on to the next slide, please. So this shows, the graph on the left shows that the majority of the drains are ultrasound guided, and it's interesting to know this given the existing guidelines. And on the right you can see how long the drains stayed in for, which tended to be 0 to 6 hours. If you move on to the next slide, please. We asked about volume of ascites that was drained, and this chart here gives us a good idea of how much fluid can be drained. If you move on to the next slide, please. And the chart on the right shows whether the patient had another paracentesis, so over 50% of patients did go on to have further paracentesis. And the chart on the right there, you can see that there was no mention of consideration in the case notes of